Very good evening, friends. Now you are watching Surgical Educator RKT. Today we are discussing about management of pancreatitis, because infection of the pancreas is a very serious type of infection. Prognosis is not good if treatment is not done promptly and adequately. Type of management of acute pancreatitis depend upon the cause, but in case of pancreatitis, first we have to resuscitate the patient, because in case of serious type of infection, different scoring system like Ranson score, Glasgow score, and Apache 2 score, Balthazar CTC weighting index, it indicate what is the prognosis. In case of severe necrotizing pancreatitis, mortality rate up more than 70% if not treatment given properly. So first we have to assess the cause and just resuscitate the patient and treat accordingly, because it is a serious type of infection. High risk consent should be taken by the relative. And in serious type of pancreatitis, management of the patients in high dependency unit or intensive care unit must, and the critical care expert also help in the management of pancreatitis. Acute pancreatitis, mostly treatment is medical. We all know the acute pancreatitis diagnosed mostly by biochemical marker like serum amylase, lipase, and lipase is the more specific for pancreas, because some other condition in case where amylase is raised, but in case amylase raised 4 times of its normal value, it indicate of pancreatitis. Now, pancreas, Pancreas. The name is a mnemonics for the treatment of pancreatitis, so we can easily understand and remember. P for pain, because pain is very severe, shooting and sudden cardinal symptom of pancreas, which is radiating towards the back. For the control of the pain, we have to give pethidine, narcotic analgesic, buscopan, pepaverine, etc. And we all know the ultimate pathogenesis of acute pancreatitis is intracellular conversion of trypsinogen into trypsin, that causing autodigestion of the pancreas. So proteolytic enzyme inhibitor like aprotinin used for the conversion of to inhibit the conversion of active form of proteolytic enzyme of pancreas. A means antibiotic. In not all case of pancreatitis, it is debatable question antibiotics should be given or not. But in case of infection, antibiotics should be given. Third generation cephalosporin, including metrozil like cefotaxime, cefuroxime, ceftazidime, meropenem, imipenem, we can use for pancreatitis, and always give metrozil because it's act against the anaerobic bacteria. Antacid, ranitidine 50 mg 8 hourly is the co-prescription of the treatment of pancreatitis. N means NPO. We keep patient NPO until infection subside. Nasogastric tube, NGT. It relieves distension of the abdomen, that causing reducing of the pain, control of vomiting, and nasogastric tube, because in case of acute pancreatitis there is a pancreatic clears, so distension of the abdomen occur. So nasogastric tube or intranasal oxygen Because in case of acute pancreatitis, because all system are involved in the case of acute pancreatitis in case due to cytokinin storm. So intranasal oxygen, and sometimes in a very serious condition there is a chances of intubation in ICU setup. C for calcium. It is very important fact is that hypercalcemia is a etiological factor for the development of pancreatitis. But in case of pancreatitis, there is a hypocalcemia and serum calcium level less than 8 milligram per deciliter indicative of poor prognosis. And where symptom of hypocalcemia occur, tetany and hypocalcemia features occur, calcium gluconate 10%, 10 ml 8 hourly should be given until the correction of the serum calcium level. Another thing, C for calcitonin, because we all know hyperparathyroidism is a cause of pancreatitis. If etiological factor considered is a hyperparathyroidism, calcitonin act against antagonist to parathyroid hormone, so we can give calcitonin. R means resuscitation of the patient, because it is a very serious type of infection, so we have to resuscitate the patient, endotracheal intubation, sometime mechanical ventilator required for the patient, because in case of severe form of acute pancreatitis there are atelectasis of lung and the alveoli of the lungs filled with the exudate, and 20% cases there is a bilateral pleural effusion, so difficulty in respiration and oxygen saturation is decreased, so sometimes. And third one is rehydration of the patient. In case of patient of acute pancreatitis, patient look dehydrated because fluid sequestration or third space fluid loss is the very serious type of complication of acute pancreatitis. So we have to correct it by the crystalloid. Most common infusion used ringer lactate or amoxicillin. E for electrolyte. In case of management of acute pancreatitis, we have to serially measure the sodium, potassium, chloride level. If there is a hyperkalemia or hypokalemia or hypernatremia, should be correct accordingly. A means antacid. S stand for somatostatin analog like octreotide, because it reduces the secretion of pancreatic juice, which is the main culprit for the development of pancreatitis. And sometime in serious condition we can use Swan-Ganz catheter for the management of the patient in ICU setup. It is all about the medical management of pancreatitis, but we have to treat the cause. First, we symptomatically improve the patient, infection, and very important thing, older days, rest to pancreas is the main concept. It is also done nowadays, but as soon as patient tolerate oral food, we have to start early enteral feeding, and the fluid resuscitation is the mainstay in the management of the pancreatitis. First is the early enteral feeding, because if we start early entering feed, it restores the mucosal variole and translocation of bacteria from the damaged mucosa should be stopped. And fluid loss, third space fluid loss should be corrected. It is the mainstay of treatment of pancreatitis. We all know pancreatitis involve each and all the organ of the body, because in case of cytokinin storm which is mediated by interleukin 1, interleukin 6 and tumor necrosis TNF alpha, tumor necrosis factor alpha. Interleukin 6 is the main culprit. In case of cytokine storm, each and every organ and system are involved, because cardiovascular system, respiratory system, urinary system, CNS, hematological system, all the systems are involved. So we have to take care of, in case of cardiovascular system is involved, there is chances of tachycardia, hypotension, pallor, changes in ECG, respiratory system, SpO2 is decreased due to atelectasis or fluid filled alveoli, or in case of pleural effusion, GIT in palatic ileus occur, distension of the abdomen, ascites is present, and if CNS is involved, then the confusion, irritability and abnormal behavior of the patient. And hematological is the DIC is the very important complication of pancreatitis, disseminated intravascular complication and disseminated intravascular coagulation, DIC, and urinary system is involved. So we have to keep hydrated patient. Up to that, we have to maintain urinary output more than 40 ml per hour. So we can manage it accordingly. Now we are thinking about the cause of the pancreatitis. Surgical management. Once the patient is stabilized, then we treat the complication surgically. First, most common cause of pancreatitis is the gallstone pancreatitis nowadays. If stone impacted in the ampoule of water, because there is a common channel of pancreatic tract and common bile duct fused together in the intramural portion of duodenum. So we have to remove the stone from the ampoule of water by ERCP and sphincterotomy and placement of the stent. But when we do ERCP in case of pancreatitis, early or elective? Early ERCP indicated only when there is a features of sepsis and cholangitis along with pancreatitis. So within 72 hours we have to do ERCP. Otherwise, after stabilization the patient, we do ERCP. Another complication of pseudopancreatic pancreatitis is a development of the pseudopancreatic cyst. It requires more than 4 weeks. Surgical intervention required if size of pseudopancreatic cyst more than 6 cm and persist more than 6 weeks. That either endoscopically drainage called cystogastroscopy, cystojejunectomy as per of the location of the cyst. In case of pancreatic abscess, CT guided aspiration of the abscess should be done. Normally, the fluid collection around the close adjacent to the pancreas resolve spontaneously, but we have to check through contrast enhanced CT scan. There is a pseudopancreatic cyst, we have to treat. There is a pancreatic abscess. If there is a necrosis of the pancreas, type of necrosis, two types: sterile necrosis or infected necrosis. Sterile necrosis of pancreas don't require any treatment. Second, infected necrosis of pancreas, we have to surgically excise. That's all. In next episode, we will discussing about the palliative management of pancreatic tumor. Thank you. Good night.